So welcome everybody, welcome from Clinique Pasteur. We are very pleased with my partner Jean Fajadet to perform this webinar that is with the support of the Medtronic. And it's a long time that we have not done this because there was this special period with, as you know, this particular the COVID outbreak. So it's really for us a pleasure to perform today this live case from Clinique Pasteur. And the topic of today is to do a case in a patient with a multivessel disease with some complex lesions. So, Jean, if you agree, maybe I can present the case.
Yeah.
Okay.
Yeah.
And then we will review. So it's a 70 years old patient with, as you mentioned, two vessel disease. As risk factor, he has dyslipidemia, he is a former smoker, and he was treated in 2017 on the circumflex, proximal circumflex, and the first diagonal branch with stent. He's quite active, and he was referred from some recurrence of angina, and he was evaluated previously of the angiography by thallium scintigraphy, which showed some lateral ischemia, 10% of the myocardium, a minor ischemia in the inferior wall, 5%, but there was no LV dysfunction. The ECG is normal. The transthoracic echo also is normal with an ejection fraction of 60%. And as this patient was symptomatic despite beta blocker, and with the result of the thallium scintigraphy, we performed thereafter a coronary angiography. The other result, next. The lab tests are quite normal. There is a normal renal function and no evidence of a particular abnormality. So this is one of the view, the baseline angiography. First, we can see that the left main is no major disease at the level of the left main. The proximal circ at the level of the stent is perfect. And there is like a trifurcation at the level of the marginal, the first marginal, second marginal, and third marginal. There is a tight lesion at the level of the second marginal, but also a significant lesion on the first marginal. Next. Once again, we see this trifurcation lesion. First marginal is probably the bigger one. We will consider that as the main branch. There is the second branch that is diseased, and the third one is very small, and probably we will discuss, but for us, it's not the major branch. That is a view from the LAD. The LAD has no disease, and the first diagonal, which was stented in 2017, was with a very good result. The right is a quite large artery. It's a dominant right, and you can see on the mid segment there is a intermediate. I will say it like this: intermediate lesion, 60%, but it's quite long, eccentric. Next, we see that on this other view, an eccentric lesion. So there was. We will discuss of that, but what to do on this lesion with the results of the thallium scintigraphy. So to summarize, a 70-year-old male patient. Previous PCI on the proximal circumflex and on the first diagonal. He has symptoms of angina with documented ischemia, in particular at the level of the lateral wall. He has a normal LV function and he has the two vessel disease. Well, we say obtuse marginal is a trifurcation, but I will say bifurcation lesion, but because we will consider only the two first branch. And there is also this right coronary artery lesion. The discussion will be, do we need to treat it, yes or no? Jean, maybe we can now review with you the angiography.
Yeah, so we are here with from 6 French guiding catheter. It's a XB 3.5 insert via the right radial artery through the 6 French sheath. And now what you could see that's the lesion on the circumflex artery. And you could see that what Bruno told you, that we have a typically trifurcation lesion, and the question is to consider what is the main vessel. We have here two possibilities to consider the first OM because it looks a little bit larger at the main vessel,
yeah,
and consider the side branch, the second OM at the side branch. What Bruno said, tell you that the distal circ, we will not touch it because it's a small, really small territory. The other option could be to consider the second OM at the main vessel. Why? Because there is a longest lesion. And we know that we will have automatically to implant a stent on the second OM and then consider the first at the side branch. That's the question. But anyway, when you consider the angle, it's around 60, 70 degrees between the two OM. So maybe we can, what you say, consider, because it looks a little bit larger, the first OM at the main vessel, and the second, which is diseased, at the side branch. So what will be the plan? First, I can show you what we have seen in the LAO.
So Jean, there is a question from our colleague about addressing the problem of how to size the stent in such eccentric and long disease calcified. I think it's a good question. I think that first the strategy will be probably to stent the first marginal.
Yeah.
Probably the fact that we will predilate will maybe help us to consider what is the size of the distal vessel, because we have to select and the stent in accordance to the distal reference diameter in order to limit the risk of side branch occlusion. Then doing that, the next step will be to do a pot at the level of the proximal part of the bifurcation. But probably if you want to address specifically the size of the stent that we will have to use here, I would say that probably it should be a 2.5, and then we need at least a 3.0 with a 3.25 at the level of
something
the
like that. Yeah. Because when you look at the proximal circumflex, it's 3 millimeter, maybe a little bit between 3 and 3.5. And so when you look at the distal bed on the first OM is around 2.5, looking at the size of the guiding catheter. Of course, the severity of the lesion, and you could see in LAO, is really an eccentric critical lesion. Maybe the distal bed, it's a little bit undersized. This is possible. But anyway, what we could do is to, what Bruno say, after placing the wire, what we could do is to place a 2.5 millimeter stent inside the circumflex and the first OM branch. And then we will see what kind of balloon, the size of balloon we will need to do the post dilatation. Okay. So what we could do is to.
So certainly I will say 2.5 for the distal. The question after is how to evaluate the proximal part, because if you consider that it's a trifurcation, probably it could be at least 3 and maybe a little bit larger. If we consider that the second branch is at least 2.5 millimeter or so, so it will be close to 3.5 for the pot at the proximal part of the.
Okay, so we start now with the first wire. The first wire is a BMW wire. It's the wire that you use usually. Maybe we need to take the same view, which is 26 by 16. 26 RAO and 16 caudal.
Okay. The guiding catheter is a 6 French, correct? Huh?
XB 375, 6 French. Okay, here you see we take the intermediate branch. So I did not make a large curve, because then we have to cross the lesion. Here we are. So here is the first OM. It was what we tried to do. I will take the talker because it's really tortuous. It's really tortuous, and maybe in this tortuous vessel, hydrophilic wire could be better. We will see. That's the first band, second band. And now what we need is to advance slowly.
When we have to figure this type of, very tortuous vessel, sometimes the other wire.
Now we have some difficulty to advance the wire in the third band. So I pull back a little bit, turn quickly the wire.
Probably,
If not, we will
use
use the balloon and we'll be held by the
Oh,
balloon.
you
What do
can
you think?
use to run through.
Oh, no, the wire. We
Yeah.
will see. It's not easy. Huh?
No.
Can we maybe have a view of that? Maybe we take a small branch. Sometimes we could not see it.
Sorry.
No.
I had bubble. I thin bubble.
Sometimes we.
Sorry for that.
I think we are in the right lumen. Huh?
Yeah.
But you see that's a difficulty
Too advanced the ball.
when we turn. We'll see. One more time. The wire is a little bit damaged. So we will take a run-through wire. Yeah. Hydrophilic wire should be normally easier to descend the wire in this tortuous vessel. We know that at the beginning, we could anticipate this. I try every time to have a BMW, use a BMW because we have a nice backup with the BM. Tu veux flusher ou...
Oui, oui. C'est bon. Flush.
J'ouvre. Okay. So, run through wire. Thank you. And then what do you think, Bruno, concerning the balloon? I think we need to predilate in order to open the vessel. So after placing the second wire in the second OM, we will advance 2.5 maybe is enough. What do you think?
Yes, 2.5 is enough.
Yeah. The support with the guiding catheter, the backup is good. Really, we have a good
okay, there was a
position of the
two question and two comment. A comment saying one of our colleagues saying that, as we mentioned before, that the second branch was probably more diseased and with a longer, disease at the proximal part, and he said that probably he will do it differently. That means stenting first the second marginal branch.
That was a question.
That is a possibility.
Yeah, absolutely. Not easy.
Not easy because the
left
stent is
the stent is at the ostium.
Yeah.
And
the other
the length is short.
Colleague asked you to show what type of tip you put at the curve of the.
It's not an aggressive tip. I will say 40 to 45 degrees angle. Quite a short tip. You see, it's not easy because
you are taking the small one.
I'm taking the small branch. So I will take a torque. It's not easy because the angulation of the wire at the ostium of the circumflex make the difficulty to cross. Now it's okay. And now we will see if it is easier to descend the wire with the hydrophilic wire compared to the BMW. We will see. Not easy.
Not easy.
You see?
The same, but
you see. So what we could do maybe is to leave the wire here, and then use the support of the balloon.
Yeah.
So don't you want the sink?
Do you want to put the second wire first, or you will advance with the support of the balloon?
We can leave the wire, the first one here.
Yeah.
And then place the second in the second OM.
Yeah.
And do the predilatation. What do we see on the first or second OM?
You see, when I see now, when we evaluate the difficulty to advance the wire in the first marginal branch, I will probably,
place the wire there.
Place the
balloon and the stent.
And the stent
here. Absolutely.
Because if we have to recross with the stent in the second marginal branch,
should be
then
difficult.
Advance the wire in the first marginal
Absolutely,
branch.
It should be more difficult.
It could be more difficult.
I fully agree.
But effectively, if we don't have the difficulty, we can do it differently with stenting the second marginal first.
Yeah. So now we will arrive in the ostium of the circumflex. not easy. All the time I hope that we are in the right channel. I do not feel any
resistance. No.
any resistance or metallic feeling. I will take the torquer. And what really makes the difficulty in this case, it's the first angulation, between the guiding and the proximal circumflex with the stent. That makes the difficulty. Here we are in the second. Test a little bit, yes. So here it's more straight.
Yeah, and it's
then
easier.
We have some angulation more distal. Not easy. Test. Oh my God.
Okay.
Here is not too bad.
Yeah.
Here is not too bad.
Yeah, that's a better position.
Here is not too bad. Okay, now we are
here.
This one in distal position. We will leave it here. And now we will predilate
with a 2.5.
With a 2.5 balloon.
When we look also now at this angulation with the stent at the level of the proximal circumflex, during the procedure we have to be very careful when we advance the stent.
True.
Because probably due to the angulation and maybe some struts at the level of the proximal, the ostium of the circ, it could be tricky to cross with the stent.
Absolutely. So I pull back the wire. I don't want to. Okay. And now the goal is to advance the balloon.
Yes, there was a comment about pulling back the guiding catheter. Effectively, it could be helpful, especially when we will advance the balloon or the stent. And you see,
that's a difficulty. And so maybe, I pull the guiding, but maybe the wire was through the struts.
You think?
If I cannot advance the 2.5 balloon, it's certainly that we have it through the wire.
So
you see?
have to replace it.
Yeah.
Probably, yeah.
I think so.
Yeah.
You see?
That's a good comment.
Okay. So I remove the balloon.
And will you
we
try
can,
to...
We can leave the balloon here.
Yeah.
And
but you will, yeah, okay. I will addressing maybe the fact to try on the second wire to see if...
Well, we can try first the first one.
Yeah.
So I pull back. I can disengage a little bit the guiding.
Yeah.
And now we will see. Oh, here we are in LAD. Yeah. So
no problem here.
So I pull back.
Here
it looks good, here. We will see.
This is the first one. This is the second one.
We can leave it here.
Yeah. That's a good position.
That's good now. Look.
Yeah.
And now what we could do, we will see
if the balloon is
if the balloon now can cross the ostium of the circumflex. I think we were. You see the difference?
Yeah. That's a good, good demonstration.
Really, the message is when you have this kind of difficulty, never force. Never force. If you cannot cross a 2.5 balloon, certainly the wire, it's through the struts of the stent. Yeah. So we have to reposition the wire.
Now you can advance the wire much easier.
Yeah. So now the wire, the distal wire is in the distal OM.
Yeah.
I will advance the first one a little bit more distal. Now we have a good position of the two wires. What we can do maybe
test.
A test. Okay. Yeah. And now we can advance a little bit maybe the balloon and we can inflate it. Okay. Good. 6, 8, 10. It's not calcified. So you see the balloon can open easily the lesion. Now what we can do is to take a view of that.
Yeah.
Test. Much better.
Much better. There is some accordion effect on the first
marginal
branch,
course,
but it's quite normal, I would say.
Yeah, but when we remove the wire, normally
it will disappear.
If there is no dissection, it should be okay. So now,
we can anticipate
concerning the size and the length of the stent, if
Yeah.
we consider the first OM at the main vessel,
Yeah.
what do you think, Bruno?
I think that if we consider the distal reference diameter, it's 2.5. About the length,
This was the balloon, 2.5.
yeah, and 15. This is a 15, so probably I will say that 15 could be enough, but well, yes, 15 could be enough.
15 or 18. 15 could be enough. Huh?
Yeah, because in fact there is the proximal stent. So
but we have to think to the pot.
Yes, but there is a stent.
But there is a stent inside, so
I think that
15 is okay.
Is okay.
Okay, 2.5, 15. And then certainly we will postulate with a 3.0 balloon.
Yeah.
Okay. So we remove back the balloon from the first OM. Leave it the two wires in the distality, and you see that I use the fluoroscopy all the time when we are doing this kind of maneuver, because we need absolutely to avoid to remove the wire, one of the wire, or sometimes the two wires.
So what will be important is when we cross with the stent, the ostium, and once again, so
Yeah.
be sure that.
So for the ostium, what I will do is to remove a little bit the guiding catheter in order to avoid to have a too acute angle, and then we will advance slowly. Here, you see, very, very slowly, and now we are in the right position. We can take a view in order to see if we need to advance a little bit more further. Yeah, here is okay, no?
It's okay, yeah, I think it's okay.
I advanced during the inflation, I advanced a little bit more distal. Test one more. I think it's okay here.
It's okay, yeah.
Go on.
Okay.
8, 10, 12. Well, we can go up to 14. It's a 2.5 vessel, no problem. Okay, 14, 16.
And then we can pull back a little bit.
Okay. So what you can do is to do a pot.
First mini pot.
With a mini pot with a short 3.0 balloon.
Yeah.
You want to here?
Yeah, to do another. Yeah.
Okay, here. Go to 20. And then after that, we will place a 3mm balloon in the proximal part of the stent using the pot, the optimization. And after that, we will take a view.
You want to
but certainly now? Yeah.
Maybe we can check.
We can check now.
Okay.
Yeah, you see that the side branch,
now, yeah.
Of course, had a problem, but the stent is correct.
The stent is good.
And the good point is that distal to the stent, there is no dissection.
No.
So what you can do now is to advance the 3mm. So we will do the pot, and after that, we will take a third wire in order to cross the threads of the stent, place the third wire in the second OM, and then after that, we will remove the jailed wire. We will advance, what do you think, 2.0 or 2.5 balloon?
I will advance
a 2.0?
2.0. Yeah.
Certainly a 2.25 millimeter stent, maybe.
If we have to
quite long, because it's quite a long lesion. Kissing balloon. And then we will finish by the final pot.
Yeah.
So these are the different steps, or what we call the tap technique. So here we have the short balloon.
Yeah.
What's the length?
It's 8.
8 millimeter. So test to be sure that you see the distal marker will be at the site of the bifurcation. I advance a little bit the balloon. Here.
It's okay. Huh?
Okay, go on. 6, 8, 10.
We have to be the distal marker of the balloon is just at the level
at the level of bifurcation. And now we can go up to 14, 16. So this is the first pot. Maybe a little bit back. 8, yeah, here. 14.
There was a question about the stent that we use. So it was a Resolute Onyx 25 by 15.
Yeah.
Yeah.
Okay, inflation. The stent was a 2515 Onyx. Okay, so we see, you saw that I remove a little bit, 1-2 millimeter, the balloon, in order to be sure that the proximal part of the stent, proximal edge, is correctly open. Now we remove the 3 millimeter balloon. We will leave what I tell you before, the jailed wire. On y va? Inside. Okay.
Okay.
And now what we could do is to take a third wire.
In order to recross in the second marginal.
Exactly.
And once again, when we look the difficulty here to advance the first wire in the wire of the first marginal, I will definitely here use a third one.
Oh yeah.
Because you have the tortuosity,
Sure.
you have the risk of crossing through the struts of the proximal stent. So probably here it's advised to use a third one and to recross and to leave the.
I don't know if you could see the shape of the wire. Maybe it could be better
So
on the here. Can you see it? That is the shape of the wire. So very difficult to see, because I will turn it. Okay, here. Sorry. Here you see the shape of the wire. In fact, there is two shapes. One distal, two bends. One distal very short, 1-2 millimeter, and the second little bit more proximal. Okay, we will try to do that. So here we will arrive inside the left main. I disengage a little bit the guiding catheter, and we see that there is a horizontalization of the tip of the guiding. And now I will advance slowly. We have to be sure that we are in.
Yeah.
I don't want to force. So this is good because we are in the LED. I pull back. I turn clockwise.
To jump in
and now we try to jump inside the circumflex. I don't want to advance with a loop because we can, but then we have to cross the struts. Yeah. So if I advance with a loop, I will destroy the distant. And I don't want to do that. So what we need to do is to do very slowly the manipulation of this is correct, of the wire. What we will try to do is to place the wire in the first OM here. And then when we are here in the first OM, what you could do is to pull back, turn a little bit clockwise, and then try to find it like that. We will see. So in order to, what the people say, to take the distal struts, I'm not sure that is a distal, but in order to try to take the distal. So what we try to do is from distality to proximal.
Oh, you take the third one.
This I take the third one. So I redo the maneuver from the first OM back, turn clockwise. Here we are. And now try to, maybe the bend is not enough.
It was okay because you
yeah, but
you were able to go in the third one.
Not easy, yeah. Too much the third one.
No.
Here is okay, no?
Right now, maybe you are at the level of the third one, but let's.
We redo it.
Yeah.
It's a matter of patience. Because if we move too fast, we will destroy the wire. That's a problem. And so we will have to take another one, a new one, etc. So what we try to do is difficult to go inside the distal. Here we are.
Yeah.
And now pull back again, clockwise. Maybe the distal bed, the distal is not enough. Here is not too bad. No.
You jump.
I jump, but maybe I'm jumping in the
third one.
Here we are.
Yeah.
It was not too easy to because of the trifurcation. When we have a bifurcation, it's
There was a question about the fact, of the interest of the pot after the final kissing. If we put a second stent on the third marginal, it just the goal of this is to reshape and to avoid to have at the zone of the kissing stent like an ovoid zone. And so probably the fact to use to do the final pot allow us to have maybe a round shape of the stent at the proximal part.
So if we do this, so this one is the
this one, you have this one. I don't know if you use it, this one.
No, this one was the
the
torquer on this one. Yeah. And this one was the, so I remove it. This one is the jail wire.
Yeah.
Now we advance the balloon on this one.
Yeah. 2-0. Okay.
So normally when we do kissing, we finish by the pot.
Yeah.
After kissing balloon. And if we place a stent, an additional stent, and then kissing, in other words, we will do certainly a tap technique. We will finish by the kissing, and then finally the last pot.
The last pot. But this pot
so the problem will be you can explain.
Too distal, because if you are a little bit distal to the level of the bifurcation, you will crush the second stent, the stent that is in the second branch. So the best is to do the pot a little bit proximal compared to a pot without a stent in the second branch.
Well, thank you for the comment.
There is a comment about.
Thank you for the comment.
It was a 2 run-through wire.
Yeah, a run-through wire.
Yeah.
Hydrophilic wire. You can do without an hydrophilic, but in this particular situation, I think hydrophilic wire is certainly the best wire. So you can take this one or another one. But hydrophilic wire is really interesting because this reduces the resistance, the friction when you advance the so here maybe we have the wire twisted, and that's the reason why we have a problem. It's okay here.
And you advance.
Okay, now we can open it. We can open the struts. Again, it's a 2.0 balloon.
You see, 2.0 is enough, huh?
Maybe the 2.25, if we need a stent, will be enough.
Yeah.
I agree. Then we will advance a little bit more because the lesion was longer than that. So what you can do is to take a view of that just to see the length of the lesion.
Yeah,
it's 20. Okay here. So maybe 18 should be enough.
18,
you open it?
Yeah, 18 or 20.
So now we have opened everything. I hope that we are not through the struts in the upper part. It's okay. I feel something, but it could be the twist of the wire. Yeah. Could be. I hope so. So
maybe we can evaluate now.
Now we can evaluate the result after the balloon inflation. It's we can have better result. Maybe with a 2.25 millimeter, it should be okay.
Yeah.
So there is two possibilities: to perform a kissing balloon,
yeah,
or to go
directly
because of the length of the
the leg,
lesion
yeah.
in the side branch to move directly
Direct
to
to
the
the
stent
second stent,
implantation in the M2. What do you think?
Probably I will, I will move directly. Yeah.
2,25 par
18.
18, ouais. So we would take Onyx 2.25 18
And we will place a 2.5 balloon on the
and a
new one.
2.5 balloon in the M1.
Ouais.
So this one is the.
Vous avez un semi-compliant, un court, on peut prendre un 10 si vous avez.
Il fera peut-être un 9 hein, là.
Oui, oui, je vais lui demander un 9, un 10.
Ça gratte un peu.
Oui.
Merci beaucoup.
Non,
d'abord
d'abord
le stent.
On va.
So the 2.25 18, I hope that we could advance it. I had some resistance.
Yeah.
You know, this metallic feeling that you can have between your fingers when we are moving the wire. It could be the twist of the stent. So this is not really a problem. We could be through the strut in proximal.
But if you
This
cross
should
with
be.
the 2.0 normally.
I hope that we could advance the wire. We will see the balloon and the stand. It's okay.
It's
Now,
okay.
so it was a twisting of the struts. Now, what I have to do, because the stand is in the proximal circ, I will advance now a little bit more the guiding catheter in order to increase the backup, the support. And now I will advance the stent inside OM2. So now what we need
is to advance the balloon. Huh?
We can take a view of that. It's
Probably
to advance. I can advance a little bit more, and we could remove it. We can place the balloon a little bit distal in the
like
in the OM.
That's good.
And now take a 2.5 balloon on the other wire. So this is typical the tap technique. And I can tell you that there will be next week on Thursday a fantastic session on PCR e-course, a fantastic session prepared by Goran Stankovic and myself. But the work of Goran was absolutely incredible. You will see a typical tap technique with, the 3D imaging of the stent inside it's a virtual imaging, and you could see all the steps of the tap. It's really fantastic. So if you have time, join us. PCR course next week is on Thursday. It's the first day of the course. The course is Thursday, Friday, and Saturday.
So there was a question about the decision to put a second stent because there was no evidence of flow limiting, TME reduction flow. And the question was, can we leave this result after balloon? That's a possibility, effectively. But probably it's a long lesion.
You see, the problem is there
was no evidence of dissection, for sure. There was no flow limiting, TME flow limit.
But so this is the result, you see. And the ostium, and it's a particularly a long lesion. It's more than 12 millimeters. It's more than the close 15 millimeter. It's not a big vessel, so the risk to have a reocclusion, it's not negligible. What do you think?
I think that here I agree with you say that we use the 2.0 balloon and we inflate at nominal pressure, and I don't think that using a 2.5 here will be will have a better result. So the question is, do we accept this result with this long lesion at the level of the branch, and possibility the difficulty to come back to do something, or because we are here we go directly with a second stent?
What do you think?
I think the position is good. So
do we need to pull back a little bit, or
I think when we look
because
for
the stand start after the marker?
yeah, but it's inside the marker, and I think that
Yeah,
when we look at, I think that for me the position is
it's
quite
not too
good.
bad.
Yeah,
It's not
yeah,
too
yeah,
bad. Huh?
yeah.
Okay,
So this is the
so
stand.
now we have two wires,
I
two deflators, one for the stand. Here you are. One for the balloon. We can inflate the balloon now.
we will pull back maybe a little bit.
Yeah, you can pull back.
Pull back.
What was the pressure?
Nominal 10.
Nominal.
10.
So we
Because
pull
it's a
back.
little bit.
Okay. So we pull back.
Dégonflé.
We pull back the balloon here.
In order to
We will take
higher pressure.
14, 16,
No.
18.
Okay. Now it's optimization of the proximal part.
Now
and now we can do
the kissing 8, 8. Okay. And now we will see the result. Even if the result is satisfactory and geographically, the work is not finished.
Yeah.
We have to come back and place a larger balloon, short balloon, using the pot, the final pot, proximal to the tap zone. And that will be very important to have a good imaging, because we have to place the distal marker of the balloon just proximal to the tap zone. And this is very, very, very important.
So there was 3 questions,
okay.
3 comments.
Go
First
on, Bruno.
one is, do we think to do a final, at the end of the procedure, to do a balloon inflation at the level of the ostium of the circumflex, because we have worked, maybe we tried with the balloon sometimes to cross through the struts in order to maybe reshape it better. This is the first one.
Yeah.
So probably that's a good comment. We can finish at this with the balloon at the level of the ostium of the circumflex. There was a comment of saying that he hoped that there was no pinch at the level of the first marginal after doing the stent on the second one. But as we put the balloon, I think that the result is quite good. I think that we don't see here any evidence of pinch, and the result here on the 2 branch are okay. And there was a comment about the angulation between the first marginal and the second marginal. Is it too much too low to do a tap? I will say that it's between 40 and 60 degrees. We are at the edge where we can do a tap, because we know that if the angle is too narrow, probably the degree of protrusion will be important. But I think that here it's quite satisfying. Yeah, I think it's quite. I think that the fact that we try to put the wire in the distal struts, probably the degree of protrusion is a little bit more important. I think that the technical issue here is to be confident that we try to cross through the distal struts, because if we cross through the distal struts, then the degree of the protrusion of the stent in this branch will be less important. So that's the main point. I think that if hopefully we take the distal struts, then we can have a good coverage of the ostium without too much protrusion in the proximal part of the bifurcation.
It's true that if you have an angle, a more acute angle between the 2 vessels, OM1, OM2, there is another possibility to do the culotte technique. This is possible. Or to do the decay crash, which is totally different. In the decay crash, you start by the side branch. But if you have started by the main branch, you can use a culotte technique. This is a possibility. So here is important, because we will have to advance slowly the wire, the balloon, proximal to the bifurcation. So I will see just. Yes, I think that we can remove the other wire. We could. Difficult. Sorry.
You are on which wire? That's
no. Is this one? But you see, oh my God, I know I have a loop.
Yeah.
But the problem is that, is it the balloon on this wire? Yes.
Yeah.
So difficult. So if not, I will remove everything.
Yeah, and you
And
recross.
we do the wire. So this one is, but you see we have two loops.
Yeah, there is two loops.
So we remove everything.
Yeah, that's
Sorry
the
for that. But when it's too complex, we have to start from zero.
Yeah.
So give me a wire, one of the both wire,
Celui qui est le moins.
celui qui est le moins ratatiné.
Yeah.
And I said it's the problem of the needle. It's a problem of the twisting of the wire
And the non-compliant balloon also.
and then when you move second the resistance, the friction with the non-compliant balloon. So I will advance a little bit the guiding in, and the guiding now is not in.
Yeah.
You see all the difficulties. Oops. So what I will do is to try to go inside sometimes the LV in order to open the guiding. If I cannot go inside the LV to open, we replace a J wire.
Yeah.
I cannot. So sorry for that.
No.
But this is life, huh?
This is not.
This is real life. Cannot turn it, huh? Curious. Okay, here we are. So we can remove the J wire, the 35. And now I will advance again the wire. I will place this wire in the main vessel. Maybe you can come back to the caudal. Same view. Okay, disengage a little bit the guiding. Now, interesting because.
Okay.
Sorry, it was open.
No, it was just maybe you don't need the injection. I give you the torque.
We can see the stent of the OM. Okay, it's not too bad. Now what we need is to place. Now this is not the right one.
You are in the distal one.
It's the second one.
Yeah.
Huh? So now we have to go inside. We can go with the wire in second one because we do the tap. We place the balloon proximal to the tap zone. But again, it's better to place in the first one. But you can leave the wire in the second, no problem. Okay, and now the balloon. So it's the same balloon. So it was already inflated one time, and it was a 3-0 NC balloon. So the profile of the 3-0 NC already open 2 times at high pressure. Of course, is a little bit more difficult to cross. So with my fingers, I try to reshape it. During this time, the nurse placed negative pressure in the deflator, and we will try.
If not, we can.
If not, we will take a new one. But again, we need to finish by the proximal balloon inflation by the pot, the final pot. Okay, the wire is now down. Okay, and now what you need is to see the bifurcation test.
It's okay. Huh?
It's not too bad. Yeah. We are proximal to the tap zone, and so we can inflate it now. Go on, 6, 8, 10, 14, 16, 18, and you see we can move in the other view just in order to see the bifurcation. It's very good. It's really proximal to the tap zone. Okay, good.
There was a question addressing for the left main stenting. Maybe we can address this question during the discussion time, because Actually, we are not on the left main. There was about maybe we want to do a balloon inflation at the level of the ostium of the stent circumflex. We say that it was a question. Because we
not sure.
not sure. Okay, because you okay.
Why do you want to do it,
No,
Bruno?
it was a comment.
I'm not sure because when you look at you see now the balloon which was already inflated,
it passed
but
without any difficulty.
We will see one more time if the balloon can cross it, the ostium of the circumflex. Where is the balloon? It's coming.
Now,
no, it's okay. No, it's really but there is no lesion. But
okay.
I think the difficulty are given by the angulation between the guiding catheter and the circumflex. That's make the difficulty. Okay, we go. Beautiful.
That's beautiful. Yeah.
That's beautiful. And look, this has two good branches. What we can do is to remove the wire, do the final nitroglycerin injection.
Yep.
And we do the final angio after intracoronary IV injection. So it's what we do systematically. Nitroglycerin before, in order to get the optimal opening of the vessel. And at the end, after all this manipulation, the final shot under nitroglycerin. Okay. It's beautiful. So what we could do is to
make a zoom.
Zoom. You see, it's a good reconstruction of the bifurcation. The good news is that there is no residual lesion, no dissection distal to the stents, and the evaluation, Bruno, your evaluation of the size of the both branches was very good.
Yeah.
2.5, 2.5, and 2.25.
Yeah.
And finally, the third one is still open. This is by chance. Yeah. It's not. So what we can do is to place the LAO because there was a critical lesion in the LAO. We could check in the LAO view. Ready?
Okay.
Beautiful.
Yeah.
Excellent.
So it's a perfect demonstration of bifurcation lesion with some difficulty. There was some technical difficulty.
No, it was not easy. It was not easy
at the level of the circumflex with already a stent, the tortuosity of the distality. So
it was not easy. That's the reason why we selected this patient because we know at the beginning that it will be quite difficult to do it. It's not a standard simple bifurcation.
Yeah.
But anyway, result is good. So it's 450.
Yeah.
I don't know, Bruno, if you want to see the right coronary artery.
We can do a shot on the right.
Just a shot, and we will see. If we have to do the right, it could take a short time. Well, we never said that before, but I think that it should be okay.
The right coronary artery was optional, I would say.
Yeah, the right is optional. Because on the thallium scintigraphy,
it's most
really the large ischemia area was in the lateral wall, yeah. And you say that it was around 15% narrowing.
Okay,
ischemia. So it was quite a large zone.
What was this? Oh, okay. There was a question. We didn't mention the size of the last balloon for the pot. It was a 3-0 non-compliant.
3-0.
For the stent, 2.5 for the first marginal branch. We do the pot on the 2.5 with a 3-0. Then we predilate the side branch with a 2.0 millimeter. Then we implant a 2.25 stent in this marginal branch, second marginal branch, with a 2.5 millimeter balloon in the first one. So 2.5 and 2.25, and then we finished by the pot with a 3-0 for the proximal circumflex.
Yeah. Okay. Just here, thinking we are. Maybe it's not critical. We will see. We will take a view here. Nitroglycerin.
Okay.
Pressure is good. So we can take some nitro.
Okay.
Need to be out. Okay, here is it. Ready?
Yep.
There is something with us.
For me,
I think it's not critical. We will take the LAU a little bit
if
cranial.
it was critical, I think
You
it
know,
will
to
give
see
more
the
ischemia.
yeah. Because it's a large dominant vessel, so if it was critical, we will have a larger ischemic zone. You see the. So we can do effectively FFR or this kind of thing, but it's not critical.
No, I
it's
think
not
we
critical.
can follow the patient.
We can leave it here
and see how he's doing.
Yeah.
Because we have done a quite long PCI now.
So I think that it's not necessary to take care of this. It's 50% lesion, but the most important is really the marginal, the result of this bifurcation. Okay.
Okay, so maybe we can move now.
So now what we can do is to move to the. We will remove this, and now we join you. Okay, so if we have now any question concerning this case of bifurcation, do not hesitate. You can send us your question, and with Bruno, we will try to answer to the question. But we select this case really to see how we can perform properly bifurcation stenting using a two-stent using the TAP technique. In this particular case, the difficulty was the first angulation between the guiding catheter and the ostium of the circumflex artery, which was already treated a few years ago by the stent with the stent implantation. And the second was the tortuosity of the distal bed of the two Owen branches. So that's the reason why first we select a quite aggressive guiding catheter using a 3.75 XB shape. It could be performed with a 3.5, but we were sure that with a 3.75 we will have a better, backup, better support with the guiding catheter. And then the possibility, when you have this kind of support, to move the catheter according to the phase of the procedure back and forth. That was the first point. The second was the selection of the hydrophilic wire. Normally in routine, Bruno and myself, we use a really standard wire. But in this particular case, we start, you saw, with a BMW wire, and we could negotiate the first curve, the second, but it was impossible to take the third curve of the first one branch. And you saw that with the hydrophilic wire, it was not simple, but really less difficult. Of course, and Bruno, during the procedure, you mentioned that when you place your wire distally, all the time when you have this kind of tortuous vessel, you have a kinking accordion effect on the vessel. This is not a big problem. You leave it. During the procedure, you have sometimes no flow in distality because of this accordion effect. But at the end of the procedure, when you remove your wire, immediately you will come back to the initial anatomy, the baseline anatomy of your vessel. So
there is some question. Yes. The first one is if in case of the occlusion of the third branch and the patient had chest pain, you open the ostium of the third branch.
What do you think?
I would say after the stenting of the two major branch, if I have a good result, even if the side branch is occluded, I will maybe not come back in order to avoid to maybe have some less good result on the two major branch. Sometimes the patient has chest pain and you come back for a small branch, and sometimes you damage the result of the target. So I think that here due to the difficulty that we had, due to the fact that we had a very good result on the two main branch, I will maybe not touch the third branch if the patient.
Yeah, but it's really the risk for this small branch will involve really a small amount of myocardium. You will take the risk to damage the tap, which was good. And by using a third wire, balloon, kissing balloon, we can have at the end a problem on the tap, in other words, on the two major vessels. So in this case,
because if you
I fully agree, I will leave it.
I will leave it. If you put a third wire, then you have to do at least a kissing, but on which branch? The second. And so if you do a kissing between the third and the second, then so it will complex a little bit the procedure.
Yeah.
A question about Dr. Costa from do we use IFR or FFR? In our cat lab, we use FFR or sometimes
Yeah.
QFR, but actually it's not always. And why? It's mainly for when we interrogate an intermediate patient when the patient has no test of ischemia
Yeah.
before the coronary angiography. So intermediate lesion or no evidence of precritical lesion and patient not evaluated by the functional test before the angiography.
Yeah.
Any tricks for stent balloon sizing? We come back to the from Dr. Gupta. Any tricks for stent balloon sizing diffuse to prevent coronary perfusion if you don't do imaging? Okay, so I think that we said at the beginning that using a balloon it helps you to precisely size the vessel. It helps, it gives you some guide, and I think that you effectively we have not done any imaging, but here when you see the difficulty of the procedure, I think I'm not sure that an IVUS probe or an OCT probe will cross easily all this tortuosity. But I think that my advice is to use the balloon as a predilatation to give you some indication about of the size of the vessel.
It's true that when you have calcified vessel, particularly heavy calcified vessel and diffuse calcification along the vessel, it's true that first the risk of perforation with the balloon, particularly if you select high pressure, is more important. Second, it's true that if you have the possibility to use imaging, intracoronary imaging, you could have a better, appreciation of the right size of the vessel, and particularly the size to do not, over in order to avoid the perforation. That's the first one. If you have not, and I know some center that you have not intracoronary imaging or are not using intracoronary imaging in routine, what you could do is to use balloon step by step, with a small balloon, then increasing half size, then increasing half size, and each time you check in order to see first if the diameter of the balloon, when the balloon is inflated, you compare your diameter of the balloon to the diameter of the proximal vessel and the distal vessel. Second, if it is really diffuse calcified, you have to look at all the vessel. In other words, could be calcified, a left main it's always 4.5 millimeter. That's the mean. A proximal LAD usually is around 3.5. A circumflex is between 3 and 3.5. That's, in 90% of the case is working like that. So if you start with a 2.5 millimeter balloon in the circumflex, and you believe that the circumflex is certainly larger, but you hesitate between 3 and 3.5, open at high pressure your 2.5 balloon. You test. Then you come back with your 3 millimeter balloon. And you take high pressure and you taste. And then you decide. If you believe that the angiographic result is correct, and you can accept the result, leave it. If you need something in addition, take a 3.5, non-compliant, and use at the beginning low pressure, and you inflate to 3.5 progressively. What you have to avoid is to take a large balloon, take 18, 20 atmosphere quite brutally, because this is the risk of increase the risk of perforation. So in fact, to summarize, step by step, increasing balloon's size, balloon diameter, and inflate the balloon slowly.
So Dr. Barik asked us two questions. First one, what was the angle between the stented vessel? I will say that the angulation was close to
40 degrees, something like that. Yeah.
And did we plan to use a tap technique before we start the procedure? Probably we have this in mind. To be honest, the difference between tap and T stenting is something difficult to see. It depends really of a minimal protrusion, no protrusion, minimal protrusion is sometimes difficult. And as we mentioned during the live, the importance to be able to do a T-stenting is to take the distal struts, because at this moment the coverage of the opposite wall of the carina will be good with the stent of the main branch, and you don't need to protrude too much in the main vessel. So tap T, I think that's clearly when you have an angulation up to 30 degrees, it's still possible. When it's less than 30 degrees, probably here we have to use the culotte, because it's not possible.
Absolutely.
To have
or we have too long protrusion inside the main branch. Yeah.
He asked us also which kind of expertise is required to handle two stents with such narrow angle between two vessels. I think that what is very important is to know the different steps. It's predilatation, then do stent the main vessel, do the pot, then recross, trying to cross the distal struts. That means that you have to go in the main vessel, going back to jump in the distal struts, open the second vessel, advance the stent with the balloon in the main vessel, deploy the second stent, etc. You have to know perfectly the different steps, and if you know these steps, it's correct. If you are comfortable with the different steps, if you know it perfectly, then the procedure will be okay.
Yeah, globally, the tap technique it's with Bruno is really the technique that we use the most often when we use two stent in the bifurcation. It's quite easy. First, it's logical. After a single stent strategy followed by the kissing balloon, you were a poor result of the side branch. Logically, it's simple to place a second stent and use a tap technique. Second, what is important is to have a good angiography, and this is very, very important for all the lesions, but particularly for this kind of bifurcation. Select the right angulation, and sometimes 5 to 10 degrees caudal or less cranial or LAO or aero change the life for your procedure. When you see it correctly with the right angulation, in this particular case it was aero 15 yes, and the caudal
5 to 10,
5 to 10, 10 degrees. 15 to 10 was really good to open and to see the bifurcation. And when we have selected the right view, in this particular case, areocaudal, then again, your life is really more simple during the procedure.
What you have to do.
Absolutely.
You understand better.
So the most important is to see exactly the lesion. And when you have seen the lesion, you zoom it, you store it on the side, and then you have just to follow the initial anatomy, the baseline anatomy.
Another comment, but we have also discussed that between the live of Dr. Al-Jabri, is that maybe we can do on the opposite. That means stented first, the second marginal, then to recross toward the first marginal. Effectively, I think that when you see such a lesion, we can do a different way. We can stent the second marginal first and recross. I think that it depends of your personal feeling about the lesion. I will say that effectively it could be easier, maybe, but it could be also more difficult. I don't know. I think that what was more important is to finish and to, as I mentioned before, to do the different steps and to finish by the final.
Yeah. And you will see, if you are really interested by this technique, again, I repeat what I say, but because I saw the final editing next week on Thursday afternoon, if you go on the site PCRE course, you will see on Thursday the session on the tap technique prepared by Goran Stankovic. it's really superb. It's really a gift for all the interventional community.
Effectively, when we see you are hearing Goran speaking of bifurcation, each time I learn something. Each time it's different. Each time he has some news, news information. So really, even for a very, very experienced operator, hearing what he's telling Goran is always
and really the quality of imaging is really impressive.
And the final question about any concern about aggressive pot with gel wire in place. I think that, whether is it advisable to recross into side branch before pot? I think that doing the pot open the strengths and will facilitate the recrossing. So it's normally it will facilitate the recrossing. I will say that aggressive pot with a gel wire in place, in our experience, is not really an issue.
No.
I don't think it's.
What's important is that when you leave the wire jailed by the stent, and when you in the side branch, and when you advance the balloon for the port in the main branch wire, you use really high pressure with this balloon in order to achieve the best as possible the pot technique and the good result of the pot. And it's true that sometimes, particularly if the length of the stent is long, proximal to the bifurcation. This was not the case here. We have just 8 millimeter. But if you have 20 millimeter, sometimes it's quite difficult. In other words, you feel it. There is one thing which is important, is to anticipate the jump of the guiding catheter inside the left main, inside the LAD or inside the circumflex in this case. So what you have to do is to disengage the guiding catheter. Sometimes you have to disengage for 1 or 2 centimeter inside the aorta. You pull your wire, jailed wire, and do this under fluoroscopy. And if you do this under fluoroscopy, you will see that when you will remove the jailed wire, you will see the guiding catheter progressively coming inside the ostium. When you are inside the ostium, you stop, you disengage again, and you redo it in order to avoid the dissection of the left main, or if you are working on the right coronary artery, the dissection of the ostium of the right coronary artery. That's very important. Anticipate the deep intubation of the guiding catheter during the removal of the jail wire.
So if the angle would have been less than 30 degrees, what would be our strategy here? What do you think?
In this particular case, when you have less than 30 degrees, and if you believe before starting that you will need 2 stents. So if you believe that 1 stent could work, you do the provisional and we will see after the kissing balloon. If we believe before starting 30 degrees that we will need 2 stents to achieve a good result, you have the possibility to use the culotte technique, starting by the side branch or by the main vessel, doesn't matter, or to use the DK crush, starting by the side branch, crush it, stand, recrush, etc. Both techniques.
Both techniques are possible. It's a personal preference.
Yeah.
I think that some operator will do always culotte, some other operator will be always DK crush. So I will say that really it depends of your feeling about what is the best technique.
Culotte for me is easier. For me it's easier, but we can do the DK crush, but culotte is easier. Concerning the result, it depends on the study. There is a recently the Giuseppe Gioia published in the JACC intervention a meta-analysis of more than 5,000 patients. And at the end, certainly this meta-analysis is in favor of the DK crash. But again, we have to know exactly what type of patient were selected for this study, selected for this meta-analysis. So it's difficult. It's difficult. But what we can say that a DK crush gives you at least similar result to the other technique.
Yeah. what is important is to always do a kissing inflation balloon. When
Yeah.
you do decay crush or
Yeah.
culotte or tap,
Yeah.
is to do your kissing inflation.
Yeah.
And if possible, to finish also by the pots. Okay. So I think that we can conclude. Thank you for your comments. Thank you for.
Thank you. Again, it
day.
was a pleasure with Bruno to show you. We hope that this case was useful for you, for your daily life. And again, do not hesitate if you have any question. You can send us question directly or via Metronic, and hope to see you so next week for
The
PCR course. You will see 3 days. Really good.
It's a new experience.
It's a new experience. We will see.
You'll see.
Okay.
Bye.
Bye bye. Have a nice evening. I hope to see you soon.
Okay.
Bye.
Bye.